All right, great. Thank you, Dr. Rahimi, for that talk. That was very informative. Our next talk this afternoon is going to be an update on asthma. We actually have a couple of talks coming up about asthma, with the one after this on biologics. But first, Dr. Theodore is going to tell us about what's up with asthma in 2025. Dr. Theodore?
Thanks so much for having me. I have no disclosures. So we'll be talking about a pretty broad topic today, which is management of asthma. So to give us a bit of a roadmap, today we'll be talking about historical context, asthma's impact, the definition of asthma and the endotypes that we think about, asthma assessment and management, current guidelines. We'll talk briefly about biologics and then also look towards the future of asthma care. So to start with some historical context, I'm starting with an article from 2012 from a 200th anniversary article in the New England Journal. Basically, the authors here provide three fictional accounts of physicians caring for a patient with asthma in 1828, 1928, and 2012 to highlight the significant advancements in our understanding of the pathophysiology, diagnosis, and treatment of asthma in the last 200 years. And I was really struck by this piece. And as you read through, the description of asthma from this fictional doctor in 1828 is strikingly similar to the asthma we see today. So they write, when a fit of dyspnea occurs, that she hears a musical noise in her chest. She recovers after inhaling steam from the spout of a kettle. They talk about how this patient has suffered since childhood, has symptoms that are more common in the spring, and that during her pregnancy, her symptoms improved. They talk about hearing wheezing, but no evidence of volume overload on exam. And this doctor diagnoses this patient with asthma and hay fever. So this sounds quite like any patient we might take care of with asthma, but where things are quite different is how this patient is managed. So you'll read this last line, the physician says, "I think she may benefit from smoking the leaf of the Diturna stramonium, also known as the thorn apple plant." And so that really brings us to learn how much the way we've managed asthma has changed over time. So again, sort of the first therapies were these asthma cigarettes, smoking the thorn apple or Jimson weed. These were alkaloids, and they're basically the basis of the antimuscarinic agents that we have today. Then you see there's been advancement since that time. So in the 1900s, adrenaline, they began to harvest adrenaline from the adrenal glands of sheep and oxen. And this was a really non-selective beta agonist. And so we've had really antimuscarinics and beta agonists for centuries. The first major advancement or revolution in asthma therapeutics was in the 1940s when personal inhalers were developed. And that has sort of continued on. So in the 1950s, non-selective beta agonists like isoproterenol were introduced, and then oral steroids were introduced as part of the management of asthma. Then in the 1960s, there was the development of albuterol with less cardiac side effects. It was a selective beta agonist. In the 1990s, long-acting beta agonists came on the scene, as well as anti-leukotrienes, combination inhalers, and our first anti-IgE therapies. And then really in the 2000s is when we've seen the advent of biologic agents for asthma. I want to talk briefly, now that we have some historic context, I want to talk briefly about the profound impact that asthma has, particularly across the world and in the United States. So asthma prevalence is high. An estimated 1 in 12 people in the US have asthma. And this is based on 2022 data, which is the most recently published data. Asthma prevalence has also increased quite a bit over time. So you can see that compared to the 1980s, when the prevalence was around 3%, it's risen to a prevalence of about 8.7% in 2024. Asthma's impact is far-reaching. It's costly at both the healthcare system level and on an individual level, and it results in millions of missed school days and work days each year. I think what's particularly striking is the amount of misuse of inhalers, with up to 70% of of patients misusing their inhalers, which speaks to the fact that we are struggling to educate and teach our patients how to use these therapies. It's also important for us to remember that not all individuals and communities are affected equally by asthma, and Black, Hispanic, and Indigenous individuals have the highest burden of disease in the US, with more frequent emergency room visits and more likely, and they're also more likely to die from asthma, with Black Americans being 3 times more likely to die from asthma. And Black women really have the worst outcomes of all. So shifting gears, over time, our understanding of the pathophysiology of asthma has increased significantly. We'll start just with a common definition. So we are all on the same page about how do we define asthma. So asthma is a complex disorder characterized by variable and recurring symptoms, such as wheeze, cough, chest tightness, and shortness of breath, variable and reversible airflow obstruction, bronchial hyperresponsiveness, and underlying inflammation. Asthma itself, though, is a very heterogeneous disease. And on the left, we have this graphic showing basically our major events in the understanding of asthma and ultimately phenotyping. You'll note that it's semi-logarithmic in scale. So while there were some advancements in the 18, and 1900s, the majority of our advancements have come in the 21st century. And really today, and you can see this has evolved over time, but today you can see that starting in the 2010s and through now, we now describe asthma as being Th2 high or Th2 low, or type 2 or non-type 2 asthma. Th2 high asthma or T2 type asthma is defined by the presence of type 2 immune cells, so eosinophils, mast cells, and Th2 cells, which are CD4 T helper cells that produce the cytokines IL-4, IL-5, and IL-13 that act on both the structural and immune cells in the airways. And these are really the targets I will mention of most of the biologic drugs that we have. As you can see, allergic, sort of type 2 examples of T2 type or type 2 asthma include allergic asthma, eosinophilic asthma, exercise-induced asthma, and aspirin-exacerbated respiratory disease, or AERD. Non-T2 type asthma, which is less common but often more severe, and is characterized by neutrophilic or postgranulocytic airway inflammation, and tends to be associated with older age or adult onset asthma, obesity, metabolic syndrome, smoking, and frankly, greater resistance to treatment with glucocorticoids. And this is really an area where we do not have good therapies, and this is a big gap in our field. So now that we're all on the same page in terms of background, we'll turn our attention a bit to the basics of asthma assessment and management. Patients referred for evaluation of asthma should have the following examination and workup: a thorough history that includes childhood allergies or eczema, family history, including a history of asthma or atopy, exposure history, so exposures both at home and at work, but also exposures to things like smoke or pollution. It's important to determine if there's a seasonality to symptoms, and also important to understand a patient's asthma triggers. Assessing for comorbidities, including obesity, reflux, or nasal polyps, all of which can affect the clinical course of asthma, is also important. And then really getting a sense of the severity of a patient's symptoms, often using tools like the Asthma Control Test or ACT, or the ACQ, which is the Asthma Control Questionnaire. Physical exam should include examination of the nasal mucosa, again, to assess for polyps, and also a skin exam to assess for things like eczema. Spirometry with bronchodilator is an essential component of the diagnosis of asthma. By definition, it's a disease of reversible obstruction on spirometry with bronchodilator. And then It is my practice and generally the practice to obtain a CBC with differential at the minimum to assess for eosinophilia, which has important implications for the way that a patient will be treated. Other workup that can be considered includes chest x-ray, allergen panel, either skin testing or blood testing, an overall IgE level. FeNO is not something that is typically done in our practice here at MGH, although it can be useful, particularly in determining if there's airway inflammation that is typical in the type 2 or Th2 high asthma. Methacholine challenge is also possible, and then the bullet was messed up here, but evaluation for asthma mimics such as ANCA testing, Aspergillus serologies, and a chest CT can also be considered depending on the patient and how they present. The goal of asthma management is really twofold, and that includes long-term symptom control. So have a patient really having few or no asthma symptoms. The hope is that they have easily controlled symptoms when they do have them, no sleep disturbance, and no limitation in the patient's physical activity. So, but not only symptoms are important, but also this idea of long-term asthma risk minimization. So avoiding exacerbations to reduce the exposure to glucocorticoids. Improved or stable personal best lung function. Again, avoiding maintenance oral glucocorticoids, and then minimizing side effects from medications. At every visit, it makes sense to ask your patient the questions of what their asthma means to them. So that's the question of what are your symptoms and how does asthma present for you? What's triggering your asthma? And then I spend a lot of time with my patients figuring out their adherence to their medications. And so that includes, do they know the names, frequency, and purpose of their medications and their inhalers? What do they like or not like about their inhalers? Are they having difficulty paying for their inhalers? And then it can sometimes be difficult to do in practice in our busy clinical days, but really drilling down at how they're using their inhalers is very important as well. Asking patients to bring their inhalers so you can actually see them take a dose of their medication to see how they're doing it. I had a patient that I found out had been just spraying her inhaler into the back of her mouth, and we wouldn't have known that if we hadn't evaluated her in the clinic. You can also use placebo inhalers for demonstrations. There are a lot of good YouTube videos about how to use inhalers, and so watching and assigning those videos to your patients, sending them a link to watch later. So important to continue to educate about side effects, particularly ways to minimize side effects, for example, using a spacer or rinsing your mouth out after use. And it's important to do this over and over again and to review it at every visit if possible. Asthma action plans are somewhat controversial. The American Academy of Allergy, Asthma, and Immunology really emphasizes asthma action plans, and they feel that they're essential for helping a patient understand and self-manage their asthma. And basically what they are is instructions about how to adjust your medications based on your symptoms or your peak flow measurements, and when to step up your therapy and when to seek help. The evidence, though, from systematic reviews are somewhat mixed. They do not tend to find many clear impacts on asthma outcomes, such as hospitalizations or emergency department visits, but they can improve quality of life. And so there is some potential benefit in the right sort of selected patient. We're going to now move into current asthma management guidelines. So I share this slide because there are so many respiratory treatments available for our patients with asthma. And of course, this is the most recent 2025 version, but I'm sure many of you have seen this in your practices in the past. There are many available therapies for patients. Unfortunately, in practice, much of what we prescribe is dictated by what's covered by insurance or what a patient is willing to take, but there is a wide range of available inhalers for patients. The longstanding treatment paradigm for asthma was this step-up regimen. So with SOB, with a short-acting beta agonist as really the mainstay of treatment. And so for many patients with mild intermittent asthma, SABA-only therapy, so a SABA PRN, was quite common. And then sort of depending on how much they were using a SABA, they would be stepped up along this treatment regimen. And so you can see, you'd add a low-dose inhaled corticosteroid, then add ICS/LABA at varying doses, and so on. However, in 2019, GINA, or the Global Initiative on Asthma, proposed a fundamental change in the asthma treatment paradigm. And they basically stated that they no longer recommended a SABA-based therapy, and they recommended basically all regimens, including a daily ICS, so a daily corticosteroid-containing inhaler to reduce exacerbations. This was sort of a long time coming. And the rationale behind this change was, first of all, that a SABA treats the symptoms, but not the disease. It doesn't address that airway inflammation that underlies asthma and is actually thought to sometimes worsen it. Patients even with mild asthma who were on these SABA-only or PRN SABA regimens remain at risk for serious adverse events. So a third of asthma deaths are in patients with only occasional symptoms. And the risk of oral steroids is real, and really a relatively small number of lifetime oral corticosteroid courses can increase a patient's risk of developing osteoporosis, diabetes, or cataracts. The other issue that was seen was that SABA, sort of starting a treatment with SABA and having that be the basis, trains patients to regard it as their primary asthma treatment. And so the other things were seen as sort of add-on when they should have been seen as the primary. And then there was sort of mounting evidence about the superiority of ICS formoterol as needed. I'm going to take us through that a little bit because it's an interesting evolution, and you sort of can see where GINA landed on their ICS formoterol recommendation. So in the 1980s and 1990s, SABA overuse was found to be associated with an increased risk of asthma-related death in case control studies. In the 1990s, studies show that ICS significantly reduces asthma-related hospitalizations and death, reduces exacerbations, controls symptoms, and improves quality of life. In the 1990s and 2000s, SABA use was found to be associated with this reduced bronchodilator response, increased airway hyperresponsiveness, increased allergic response, and increased eosinophilic inflammation, so really working against us. And then in the 2000s, as we started to study ICS formoterol more, this idea of maintenance reliever therapy significantly reduced exacerbations in moderate to severe asthma. So even with that, sort of following that, in 2014, GINA was already starting to move away from SABA-only treatment and really for patients with the mildest symptoms. And then they started to study ICS formoterol compared to SABA-only therapies, even in mild asthma. And we saw really that there was superiority or non-inferiority at the very least of ICS formoterol. And so by 2019, GINA found sufficient evidence to recommend against SABA-only treatment. So what is the evidence for PRN ICS formoterol in mild asthma? So when compared to PRN SABA, the risk of severe exacerbations was reduced by 60 to 64%. So when comparing ICS formoterol to PRN SABA. And that was in the Sigma-1 and Novel Start trials. And you can see that here, the top graph is from Novel Start, and the exacerbation rate, this is serious exacerbations in general, and serious exacerbations is lower in the ICS group compared to SABA. And also for severe exacerbations, it's also lower than just ICS, ICS-based therapies. And then when comparing ICS formoterol to low-dose maintenance ICS, the risk of severe exacerbations was similar in the Sigma trials and lower in the Novel Start and Practical trials. There was a small difference in some other outcomes favoring maintenance ICS, but PRN ICS formoterol was strongly preferred by patients. And so all of this taken together resulted in these recommendations. So now the recommendation is really to take an anti-inflammatory reliever approach to inhalers, also known as AIR. So that is an ICS formoterol or ICS SABA, although most of this is ICS formoterol, so Symbicort, Breyna, or Dulera. And how it works is it provides symptom relief as well as a dose of ICS. So if you feel like you need to, I always tell my patients, I feel like if you need to use your inhaler, it probably means we need to also do something to get to the root cause of why you're needing to use it. So there's either an air-only regimen or a maintenance and reliever therapy regimen, or MART. So, and that depends on sort of what step in asthma you are. This is from the most recent GINA guidelines for step-up therapy for asthma. So steps 1 and 2 use an air-only approach. So that means the patient will just use low-dose ICS formoterol as needed. And then as you get into step 3, 4, or 5, you have a daily maintenance ICS formoterol, and then also use ICS formoterol as your as-needed therapy. The evidence for MART is good. So this has really become my first line for my patients requiring daily asthma treatment. So using a maintenance and reliever therapy, it has been called SMART at times as well, but MART or SMART results in approximately a 30 to 40% reduction in the risk of future exacerbation. So that's steroids, hospitalizations, or ED visits. And you can just sort of see across the board in these systematic reviews and meta-analyses favoring SMART therapy over really any other combination therapy. So same dose ICS LABA, higher dose ICS LABA, or ICS alone. In terms of prescribing, budesonide formoterol, for prescribing for MART, budesonide formoterol typically should be prescribed at the 160 and 4.5 dosing. And the Dulera or the beclomethasone formoterol should be used at the 10 and 6 dosing. Again, we've talked a little bit about this already, but the step-up therapy is such that for air only, you take 1 puff as needed. Step 3 is 1 inhalation twice, or even just once daily, plus a puff as needed. And then going into step 4 and 5, it's 2 inhalations twice daily, plus a puff as needed throughout the day, with a maximum of 12 inhalations in a day. Although I do tell my patients that if they're using their inhalers up to 12 puffs a day, I want to hear about it because that means that their symptoms are not well controlled in their current regimen. There is, so GINA, this is all from GINA's recommendations. There is an alternative controller and reliever regimen, and this is track 2. So sometimes, for whatever reason, track 1, which is the preferred strategy, is not possible. And this might be due to something like insurance or patient preference, or the fact that they're actually doing quite well on their regimen as they are. And so basically, you can see the step up here. But the idea is that you should be taking ICS when you're taking your SABA. If you're in step 1, and then if you have an ICS LABA-based regimen, you can use an ICS SABA reliever or an as-needed SABA. So I do have patients in this track, largely when their insurance doesn't cover a Symbicort or Breyna, for example. So the data for ICS SABA, this is relatively new. This was Air Supra was approved in January 2023. And basically, compared to as-needed SABA alone, it has a reduced risk for severe exacerbation. And it tends to be the most beneficial in patients who are already on a low-dose maintenance LABA, so people that already have some amount of constant symptoms that require daily ICS LABA. When you get to step 5, you can think about adding on a LAMA. LAMA should not be used as monotherapy without ICS due to a risk of severe exacerbations, but they can be added on, or if for some reason a LABA cannot be used, it can also be used with ICS. The evidence for adding on LAMAs is that there should be a small increase in lung function, although perhaps not clinically significant, and really importantly, a modest overall reduction in exacerbations. But you should be on at least a medium dose ICS LABA before considering adding on a LAMA. And I really see this as a sort of add-on once you're really maxed on your ICS LABA. So now we're going to shift gears and talk for a few minutes about biologic agents. There'll be more on this later today, is my understanding, but to give an overview of the biologics that we have available for patients with asthma. So the percentage of patients with asthma who require biologic therapy is, it's generally similar to the patients with severe asthma. So that's up to 10% of adults have what would be considered severe asthma that might necessitate biologic therapy. And this is used as an add-on treatment above your inhalers to reduce the overall disease burden. So if you're uncontrolled despite being on high dose inhaled steroids and other controllers, this is a good option. Biologics really represent significant advancement in how we manage asthma, and are a really good option for some of our patients who are not responding well to conventional therapies. You can see here, and I apologize that it's small, we'll go into them briefly, but you can see here the 6 major biologic agents that we have available to us. They predominantly work on the type 2 high asthma pathways, although tezepelumab, which we'll talk about, can be used in both type 2 high and type 2 low asthma. The 6 FDA-approved biologic agents are omalizumab or Xolair, mepolizumab or Nucala, reslizumab or Sinqair, which I've never prescribed, benralizumab or Fasenra, dupilumab or Dupixent, and tezepelumab or Tezspire. They all basically do the same thing. So they decrease exacerbations, decrease symptoms, and improve quality of life. Some have variable impacts on FEV1 or lung function. And there's some variability in how well you're able to wean oral corticosteroids, but for the most part, they have very similar clinical effects. So that's not really how you choose your biologic agent. The way that I recommend choosing a biologic is using the following mnemonic, which I learned about in a great asthma podcast. Basically, it's the ABCDE algorithm or technique for choosing a biologic. So first is looking at the age of the patient and when they had the age of asthma onset. B is biomarkers, so looking at their FeNO or eosinophil count or IgE level. C is assessing their comorbidities. So do they have nasal polyposis or urticaria or atopic dermatitis and may benefit from one agent over the other. How the biologic is dosed, so the frequency, if it's sub-Q versus IV, if it's given in office or at home. And then finally, the eligibility. So do they reach the eosinophil threshold that it will be covered, for example, by insurance? Other things that fit less well in the mnemonic or the algorithm are things like insurance coverage and cost, and of course, patient preference. Sometimes patients have seen an ad on TV and they want only that biologic that they've heard about. So going back to our initial chart, you can see that depending on depending on the patient, one may be more useful than another. So, for example, omalizumab has very strict serum IgE levels. You have to be within a range of 30 to 700 for an IgE. But it could be really good, for example, if you have chronic idiopathic urticaria or nasal polyposis disease. The risks of omalizumab include anaphylaxis, so important when we're educating or telling our patients about these medications. Nucala can be used in EGPA and again with sinus disease, and so that's something to think about. making sure it is associated with a slightly higher risk of zoster. And so making sure that a patient has had a shingles vaccine before starting it is advised. Reslizumab is an IV formulation and it's weight-based. So if you have a larger patient for whom you're worried about if 100 of mepolizumab is going to be enough, this might be a good option, although it does also have an associated anaphylaxis risk. Benralizumab has the benefit of being an every 8-week injection. So for patients for whom adherence may be more difficult or who are more concerned about injections, that may be a good option. Dupilumab, on the other side of the coin, is a very frequent dosing with every 2 weeks, but it has sort of a wide range of indications, and you don't need to reach certain eosinophil thresholds to prescribe it. And then tezepelumab or Tezspire is approved for severe asthma regardless of the eosinophils, although it has sort of more benefit in those with higher blood eosinophils. But it can be used again for type 2 low and type 2 high and type 2 low asthma. So this is one that if you really don't have as much of a type 2 high picture, might be the best option. It's important to monitor your response to the biologic therapies that you're giving your patients. And so that means looking at decrease in exacerbation rates, decrease in symptoms, improved asthma control in general. If somebody has been on oral steroids, it's looking at, are we able to dose reduce them at the very least? And then it's also important to decide if they have a poor response. So if they've had no change, perhaps you need to reassess your differential diagnosis, but also you could look to try a new biologic. It does take 4 to 6 months to make sure that to really see the full effects. But once you reach that point, it is certainly something that you can readjust. And I've certainly cycled my patients through multiple biologics in the past before finding one that works for them. In the last few minutes, we'll talk a bit about the future of asthma care and management. So we have these 6 biologic agents that are approved, but there are plenty more that are coming down the line. Again, the hope is over time to move towards more personalized treatment strategies for both patients with type 2 and non-type 2 asthma, although again, there's still a scarcity of options for non-type 2 disease. I'm not going to go through all of these, but these are just some coming down the pipe. I think sort of most interesting are some PO options. So a Bruton tyrosine kinase inhibitor, or for example, this damiprexol, which I think is very interesting. This was an ALS drug that's oral that they sort of incidentally found decreased eosinophil development and actually in studies increased FEV1. So there are some oral options coming as well as some other targets, including some targets, hopefully for more of this non-type 2 inflammation. Also on the horizon are, biologics that are sort of more easily adhered to or more convenient. So inhaled biologics or ultra long acting biologics. So this might be a biologic that you take every 6 months, for example. There's also work towards improved monitoring. So that's providing patients with digital or smart inhalers. So every time they use their inhaler, it's recorded in an app that can then come to you as the physician. Really leveraging telemedicine and having patients see their physicians more frequently, using technology to help us with that can be useful. And then also really importantly, thinking about the future of asthma is how do we decrease the environmental impact of asthma? That's of course a topic in and of itself, but the current inhalers, particularly HFAs, contribute significantly to global warming. And so looking towards low global warming potential HFAs or MDIs, new propellants and things like this is going to be important moving forward. So in summary, asthma remains a significant health problem. The overall recommendation is to use ICS formoterol-based regimens when possible. You can use the ABCDE algorithm to choose a biologic for severe asthma, and continue to be on the lookout for advances in inhalers, including smart inhalers and low global warming potential inhalers. And with that, thank you so much for your time.